Hello. So, new case today. Let's start. An elderly man presents with productive cough with rusty colored sputum, sharp right sided chest pain, fever, and chills. On examination, increased pruritus, dullness to percussion, and bronchial breath sounds to auscultation are present on the lower right side of the chest. Chest x ray shows right lower lobe consolidation, and gram stain of sputum shows gram positive diplococci. Patient is treated with cephalosporins. So, I think you know this answer because it is most of the clues are given in the question itself. So all of you have guessed it right. It is pneumonia, and it is lobar pneumonia mostly because it is a lower lobe consolidation on right side. So it is located to only one lobe, and there is no history of hospitalization or hospital acquired infection. So it is most probably community acquired lobar pneumonia. The gram staining of sputum is showing gram-positive diplococci, though it is most likely Streptococcus pneumoniae or pneumococci. So let us see its pathogenesis in detail. So Streptococcus pneumoniae is the most common cause of community-acquired lobar pneumonia. The risk factor for acquisition include extremes of age, that means either too young or too old, crowded living condition, that means overcrowding, cigarette smoking, alcohol use disorder, and certain races or ethnicities like Black Americans and Native Americans, they are more susceptible. Antecedent viral infection, mainly influenza, also predisposes to pneumococcal pneumonia. Now, this Streptococcus pneumoniae, they spread by respiratory droplets. So they colonize the nasopharyngeal epithelium on inhalation, and particularly this is more happened when clearance of respiratory secretion is hampered by either viral infection, smoking, or allergy. So after colonization, it evades the host defense because it has a capsule surrounding it. So it escapes phagocytosis. Plus, it releases an enzyme known as IgA protease. So it will cleave the IgA antibody in the mucus, which provides us local immunity. So by these two factors, it will evade our host immune defenses. And colonization is an active process in which the bacterial antigen is incorporated by dendritic cells, and then it is processed leading to antibody production. Now, from nasopharyngeal epithelium, it can spread to anatomically connected structure, for example, middle ear and sinus, and trigger inflammation there, resulting in either middle ear inflammation, that is known as otitis media, or sinus inflammation, paranasal sinus inflammation, which is known as sinusitis. If these nasopharyngeal secretions they are carried into lungs, which is known as aspiration, and they are not cleared rapidly and effectively before antibody is produced, then there also they stimulate inflammation, and then they disseminate through pores of cone, causing the lobar pneumonia. And if host cells lack any kind of antibody response, or there are some other immune abnormalities like neutropenia or abnormal neutrophil function, or the spleen is not there, or spleen is not functioning properly, or other immunosuppressive condition, then this invasive bacterial strain they reach the lung lymphatics, and from there it enters into the systemic circulation, which is known as bacteremia. And then they seed the target organs, that means all the organs supplied by blood, and there they stimulate inflammation, which is known as invasive pneumococcal disease or IPD. The commonly involved organs are meninges, so pneumococcal meningitis is very common. Other manifestations are osteomyelitis, septic arthritis, and endocarditis. Now, so far, bacteremic pneumococcal pneumonia with or without empyema, that is pus collection in pleural cavity, is by far the most common presentation of invasive pneumococcal disease, followed by pneumococcal bacteremia, in which there is no source which can be identified. Now, what could be the clinical features of this condition? Now, the classical syndrome, which is associated with pneumococcal pneumonia, is basically abrupt onset of fever with chills, cough, and pleuritic chest pain. That was in pre-antibiotic era, and it was commonly seen in young adults. But today, in antibiotic era, we see that more older adults are affected, and onset is usually more gradual, and respiratory symptoms are not that much pronounced. But yes, you can say that still the symptoms are same, that is fever, productive cough, and pleuritic chest pain. Now, coming to complications, so we know that empyema is the most common complication. Empyema is basically pus collection in the pleural cavity. The endocarditis, pericarditis, and septic arthritis are other manifestations of invasive pneumococcal disease. Meningitis can occur commonly, but it is typically apparent at presentation. So it is not a late complication which you will encounter later on. And in hospitalized cases, we have seen that mortality is up to 7 to 15%. That is a high number. Now, community acquired pneumonia, let us see a little bit about it. So, community acquired pneumonia is basically pneumonia which is not acquired in hospital, it is acquired in community. So, the primary causes are usually respiratory viruses. For example, we have seen that SARS coronavirus 2 during the pandemic. But conventional bacteria, for example, pneumococci, Haemophilus influenza, Moraxella catarrhalis, and unconventional bacteria, for example, Legionella, Mycoplasma, and Chlamydophila pneumoniae, they are common causes of this community-acquired pneumonia. That means typical as well as atypical bacteria, both are very common causes. Now, distribution of this pathogen can change based upon your location, your rate of pneumococcal vaccination, individual risk factors, time of year, and severity of pneumonia. Fungal infection, though they are rare for community-acquired pneumonia in healthy adults, but yes, histoplasma, capsulatum, coccidioides, such fungi can affect both healthy as well as immunocompromised patients, usually in the endemic region. So, if you are in an endemic region, then you should also keep these fungus in mind for CAP, that is community-acquired pneumonia differential. Now, can we get some clue based on risk factors? Yes, we can have some clue based on which risk factors you have so that you can get an idea that, okay, which pathogen I should be looking for or which pathogen I should keep in mind first. For example, if there is history of travel or residence in Southeast Asia or East Asia, then yes, you should think for viruses, mainly SARS, corona, avian influenza like H5N1, H7N9, as well as a bacteria known as Burkholderia pseudomyla. If travel or residence in Arabian Peninsula, then MERS-CoV, that is Middle East Respiratory Syndrome coronavirus, should be kept in mind. If you know that okay, person is coming from a community where influenza virus is very active, then yes, obviously influenza should be kept in mind. But also keep in mind that secondary infection with bacteria like Streptococcus pneumoniae, Staphylococcus aureus, and Haemophilus influenza are also common in such cases. If you see that cough is more than for 2 weeks and it ends in a whoop or there is vomiting followed by this cough, then obviously pertussis has to be kept in mind, which is caused by a bacteria known as Bordetella pertussis. If person is suffering from some kind of structural lung disease, for example, bronchiectasis, then you should look for the Pseudomonas, Burkholderia, Secretia, or Staphylococcus aureus. If person is an injection drug user or IV drug user, then you should look for Staphylococcus aureus, anaerobic bacteria, Mycobacteria tuberculosis, and Streptococcus pneumoniae. If history of endobronchial obstruction is there, then anaerobes, pneumococci, Haemophilus influenza, and Staphylococcus aureus should be kept in mind. If there is a context of bioterrorism, then anthrax, plagued by Yersinia pestis, and Francisella tularensis, that is tularemia, also should be sought for. So this is about the risk factor and specific pathogen. And you see in various examination, they taste this case scenario and they give you at least one of these risk factor, and then you have to choose for most likely pathogen based on the other history. So I think this table will be helpful in that regard, and I have kept it specifically for that reason. Now, investigations, which investigation you should do if you're suspecting a pneumococcal infection? First of all, you have to take sample based on what is your infection type. For example, if it is pneumonia, then you should take sputum or bronchoalveolar lavage. If you're suspecting bacteremia or sepsis, you should take blood. If it is meningitis, you should take CSF. If you're seeing osteomyelitis or any other purulent conditions, then swab or aspirate should be taken. And you can send this sample for culture and antibiotic susceptibility along with microscopy. So you will see that gram positive lanceolate shaped diplopia